My name is Sarah Buca, and this is my population health issue presentation part 1. I'm doing hypertension in males 55 to 75 years of age. Hypertension is the pressure of blood pushing against the artery walls that is consistently too high. It is often asymptomatic and referred to as a silent killer because it has no symptoms, but the damage still occurs within the body. Over time, it can lead to serious adverse health outcomes such as CAD, stroke, heart attack, PAD, kidney failure and disease, eye damage, and heart failure. Risk factors include chronic conditions such as kidney disease, diabetes, hormone problems, high cholesterol. Then there's unhealthy diet, high in salt, fat, or cholesterol, obesity, tobacco and alcohol use, physical inactivity, genetics and family history, stress, older age, risk for hypertension increases with age, race and ethnicity. Non-Hispanic blacks are more likely to have hypertension than other races. Here's the categories for blood pressure. Hypertension is considered systolic with 130 to 139, or diastolic to 80/89, and there's stage 2 and then hypertensive crisis. For diagnosis, the healthcare provider's office, it should not be made on a single visit unless it's greater than or equal to 180/110 with evidence of cardiovascular disease. It should be confirmed and obtained in 2 to 3 office visits in 1 to 4 week intervals. If possible, for an accurate diagnosis, it should be taken out of office and monitored by patients at home or with 24-hour ambulatory blood pressure. Treatment for hypertension includes lifestyle modifications such as weight loss, dietary changes, physical activity, decrease in alcohol consumption, and cessation of tobacco use. Antihypertensive drug treatments include first line, which is thiazide diuretics, ACE, ARBs, and calcium channel blockers. And then there also is a second line of treatments. Optimal blood pressure goals for adults less than 65 years with hypertension is less than 130/80, and then optimal goal for adults greater than 65 is systolic less than 130. I'm interested in this issue as this is primarily the patient population I care for while working in a cardiac intensive care unit. For epidemiologic data in Philadelphia, morbidity rates. In 2015 and 2017, the prevalence of adult males with hypertension citywide was 35%, non-Hispanic blacks was 42%, non-Hispanic whites was 36%. In 2019, 34% of male and female adults had hypertension. 2017 to 2020, the prevalence of male and female adults with hypertension by race and ethnicity. Citywide was 42%, non-Hispanic blacks was 52.2%, non-Hispanic whites was 37.3%, Hispanics was 19.3%, and non-Hispanic Asians were 5%. For mortality rates in 2022, adult males 18 years old and older, essential hypertension and hypertensive renal disease were 15th in the top 15 leading causes of death for this specific population. The number of deaths was 64 out of 749,447, which was the total population for this specific group. Underlying cause of death was essential hypertension. The number of deaths was 34 out of 749,447. In 2022, for adult males ages 55 to 74, essential hypertension and hypertensive renal disease were 13th in the top 15 leading causes of death for this specific population. Epidemiologic data for the state of Pennsylvania, morbidity rates. In 2021, the prevalence of adult males 18 years and older with hypertension was 37%. In 2021, 60% of male and female adults 65 years and older had hypertension. Mortality rates. In 2022, adult males 18 years of age and older, essential hypertension and hypertensive renal disease were 15th in the top 15 leading causes of death for this specific population. Number of deaths was 1,368 out of 12,964,056, which was the total for this specific population. Underlying cause of death was essential hypertension. The number of deaths was 885 out of 12,964,056. 2022 adult males 55 to 74, essential hypertension and hypertensive renal disease were 13th in the top 15 leading causes of death for this population. Number of deaths was 263 out of 1,585,646, which was the total population. Underlying cause of death was essential hypertension. The number of deaths were 200 out of 1,585,646. For epidemiologic data for the United States of America, morbidity rates in 2017 to 2020, prevalence of adult males 18 years and older with hypertension was 50.6%, or 60.8 million out of a total population of 120.1 million. The prevalence of male and female adults 65 years and older with hypertension was 77.1%, or 39.4 million out of a total population of 51.1 million. The prevalence of male and female adults with hypertension was 48%, or 119.9 million out of a total population of 249 million people. Mortality rates for 2022 adult males 18 years and older, essential hypertension and hypertensive renal disease were 15th in the top 15 leading causes of death. Number of deaths were 20,217 out of 164,384,742, which was the total for this population. Underlying cause of death was essential hypertension. The number of deaths were 12,722 out of 164,384,742. For 2022 adult males ages 55 to 74, essential hypertension, hypertensive renal disease were 13th in the top 15 leading causes of death. Number of deaths were 7,938 out of 36,832,404, which was the total for this population. Underlying cause of death was essential hypertension. Number of deaths were 5,637 out of 36,832,404. For global epidemiologic data, hypertension affects more than 1 billion individual or 1 in 4 adults worldwide. For morbidity rates, in 2019, adult males aged 39 to 70 years of age, 652 million had hypertension, 49% were diagnosed with hypertension, 38% were treated, 18% achieved blood pressure control, and 20% were treated but not controlled, and 11% were diagnosed but not treated. For mortality rates, in 2019, the number of deaths in adult males from high systolic blood pressure was 5.6 million. And in 2019, the number of deaths in male and female adults related to hypertension was 10.8 million. For the global burden of disease, globally for high systolic blood pressure in 2019, males and females, disability-adjusted life years was 235 million. For high systolic blood pressure was the second leading level 2 risk factor for DALYs. Years of life lost was 214 million. Years of healthy life lost due to disability is 21.2 million. And for males specifically, DALYs was 133 million. Years of life lost was 123 million, and years of healthy life lost due to disability was 9.81 million. For population health risk analysis, while there are several modifiable and non-modifiable factors that contribute to hypertension, another risk factor that needs to be prioritized is the social determinants of health. They are the environmental conditions that shape the lives of everyday health. They comprise of where people were born, live, work, play, worship, and age, which can all affect functioning, health risk, and quality of life outcomes. There are 5 key determinants: economic stability, social and community context, health and healthcare, education, neighborhood, and built environment. These can be leading driving factors of health as they affect physiology, biology, health factors, health behaviors, clinical outcomes, clinical management, and community health. Economic stability in health and healthcare is another social determinant of health that greatly affects my population. In Philadelphia, the unemployment rate in 2021 was 9.2%, while the U.S. unemployment was 5.4%. Uninsured adults in 2020 was 10%. Poverty in 2022 was 22.8%. And homelessness in 2020 was 5,634. Unemployment can adversely affect health outcomes and may lead individuals to potentially being uninsured, furthering them to have less affordable health care and are not protected financially from unexpected healthcare costs. Unemployed individuals also have a tendency to suffer from stress-related illnesses. To detect, treat, and control hypertension, access to health insurance and health care is a critical factor. A lack of insurance exacerbates barriers and challenges to successful hypertension management and care. Evidence from observational studies have shown that in lower socioeconomic groups, hypertension is more common and more poorly controlled. A study was conducted to examine household incomes with blood pressure control and outcomes in males and females 55 and older, and all participants were provided uniform hypertension treatment and access to care. Even with access to care and treatment, it was found that with low household income was associated with poor blood pressure control and increased risk of outcomes when compared to high-income households. Another social determinant of health that greatly affects my population in Philadelphia is education. In Philadelphia, high school diploma completion 2017 to 2021 was 87%. Some college in 2017 to 2021 was 66%. Bachelor's degree or higher from 2017 to 2021 was 32.5%. The National Health and Nutrition Examination Survey is a cross-sectional survey utilizing data from 2017 to March 2020 to study health outcomes and produce nationally representative estimates. The study found that in males, the prevalence of hypertension was lowest among those with college degree or above, 43.3%. The prevalence of hypertension was 52% in those with less than a high school diploma and 50.3% in those with high school diploma and some college. Education level may influence hypertension through health behaviors, health literacy, employment opportunities, or income. For example, individuals with poor health literacy are more likely to be non-compliant, especially with medication. Evidence suggests that the level of education has an inverse relationship with hypertension. Individuals with lower levels of educational attainment have a higher prevalence of developing hypertension and other cardiovascular disease risk factors. Neighborhood and the built environment is a significant social determinant of health that greatly affects my population in Philadelphia. In Philadelphia, the violent crime rate in 2021 was 15,013. Major crime rate in 2021 was 68,338. Homicides in 2021 was 562. The number of people shot in Philadelphia in 2021 was 2,326. 65% of Philadelphians reported hearing gunshots in their neighborhood. By race and ethnicity, non-Hispanic blacks was 78%, Hispanic was 76%, and non-Hispanic white was 46%. Epidemiology studies have provided evidence that there is a positive association between health conditions, including hypertension, and chronic exposure to violent crimes. The association can be explained by the effect of violent crimes on disease management activities, health behaviors, and physiological stress response. Physiological stress response. Over time, the body adapts to adverse physical and psychological situations and can trigger prolonged aberrant adrenergic activity, oxidative damage, and vascular reactivity. Studies have suggested there is an inverse relationship between physical activity and violent crime. Physical inactivity was associated with the fear of violence. Physical inactivity rate in Philadelphia in 2020 was 30%. Other studies have found a decrease in daily consumption of fruits and vegetables and prescription filling delays. A cross-sectional study was conducted in Chicago, Illinois, and found chronic exposure to higher rates of violent crime was consistently associated with an increase in blood pressure. Incremental and cumulative stress from non-lethal and everyday violent crimes such as robbery may play a more significant role in physical health. Non-lethal violent crimes may be perceived as random or impersonal events and can affect daily activities such as decreased physical activity. Homicide exposure alone was inconsistently associated with blood pressure status, which could be explained by homicides being perceived as targeted events. As everyday violent crimes had a stronger association with health and homicide, it is essential to intervene in the high crime communities to mitigate the harmful effects of everyday violent crime. Race and ethnicity is another factor that greatly affects my population. Disparities in hypertension among racial and ethnic minorities are well established. A study was conducted to further examine the racial and ethnic disparities in hypertension control cascade, the prevalence, awareness, treatment, and control of hypertension, and as you can see the results below. The study found that 29.8% of Hispanic Americans and 32.6% of Asian Americans reported poor fluency in English. Limited proficiency in English is a healthcare barrier Hispanic and Asian Americans often face, which can be associated with increased rates of uncontrolled and undiagnosed hypertension. Black adults had a higher prevalence of hypertension when compared to white adults. Despite lifestyle and diet differences contributing to this disparity, socioeconomic factors to accessing exercise, quality health care, and healthy foods, as well as the effects of systemic and structural racism, may increase the burden of hypertension amongst Black Americans. Black Americans had a lower rate of controlled blood pressure, which is unlikely related to the rate of treatment and awareness based on the study's findings. This may be a result of socioeconomic inequality, as individuals with low incomes face greater barriers in accessing health care and may not be able to financially afford it. The disparity differences noted in this study can be utilized to inform targeted public health efforts to reduce the burden of hypertension and promote health equity in the U.S. For Healthy People 2030 objectives, by 2030, increased control of hypertension in adults target is 18.9%. Most recent data from 2017 to 2020 was 16.1% of adults 18 years and older had hypertension under control. And then reduced proportion of hypertension in adults target is 42.6%. Most recent data from 2017 to 2020 was 45.7% of adults 18 years and older had hypertension. A Global Health Initiative action is the Global Hearts Initiative, led by the WHO and the CDC. The implementation of Hearts in the Americas is led by the Mental Health of the Pan American Health Organization and the Department of Non-Communicable Diseases. Hearts is expanding and being implemented in 32 countries covering 30 million adults. The Hearts created population-based treatment protocols for the improvement of hypertension. The clinical pathways were developed to help countries standardize protocols for hypertension treatment, and as you can see to the right are two examples. For national and local actions, the National Hypertension Control Initiative was launched by the American Heart Association as evidence-based and community-driven effort to decrease the prevalence of hypertension. In 2022, the American Heart distributed over 75 blood pressure cuffs and resource guides to community and clinical partners in Philadelphia. American Heart also partnered with Philadelphia healthcare organizations and community clinics to launch 3 self-measured blood pressure monitoring initiatives, which impacted 42,221 individuals. Locally, Jefferson Health in Philadelphia offers community health programs. The Blood Pressure Plus program educates the Philadelphia communities about the risks of hypertension and offers monthly blood pressure screenings in different areas of the city. As previously mentioned, there are several modifiable and non-modifiable factors that contribute to hypertension, but another factor that needs to be prioritized is social determinants of health. While the social determinants of health are contributing components to health inequities, it is important for nurses to identify the disadvantages and intervene to promote health equity for all. In Philadelphia, it is essential for nurses to include interventions on primary, secondary, and tertiary prevention levels to improve the population's health. To be continued on presentation 2.